Good afternoon, everybody. I'll talk on the management of traumatic retinal detachment. Traumatic retinal detachment comprises around 10% of total RD cases. It is from a very old study. Maybe the real scenario is more. RD may occur due to direct retinal perforation, contusion, and vitreous traction. Contusion is more common in blood and trauma. Approximately 75% of traumatic RD are rhegmatogenous. Retinal breaks may be acute or late. Dialysis comprises around 40 to 50%. SST or GRT may comprise 20 to 30%. Atrophic tear comprises 15 to 20%, and laceration around 10 to 15%. So, clinical presentation, traumatic retinal detachment are usually shallow and often show signs of chronicity. This is a classical scenario, but this may vary from case to case. Clinical presentation of the RD is usually as follows: 12% immediately, 30% within first month, 50% within 8 months, and 80% within 2 years. So, coming to management, how it differs from other RD, rhegmatogenous RD cases. First scenario, it is often accompanied by other conditions like media opacity, vitreous hemorrhage may be there, traumatic cataract may be there, or subluxation may be there, corneal edema may be there, or cornea opacity may be there, and hyphema may be. Often the ocular coat integrity is also associated. So in some cases there is eye external injury may be very obvious, which may need repair. Sometimes in the second picture down, it may be detected during operation, and in the worst case you can detect a posterior scleral wound, perforation wound, exitome. So intraocular foreign body is often associated with traumatic RD, so it is necessary to detect the intraocular foreign body and remove it along with RD repair. Choroidal or subretinal hemorrhage may be associated, and optic nerve injury is also maybe one condition that may determine the prognosis. So PVR, it is one of the most important prognostic determinant in traumatic RD cases, and often this PVR may be very aggressive, and risk of PVR is associated with severity of injury, pre-existing retinal pathology, vitreous hemorrhage, vitreous prolapse, long posteriorly located on, and persistent inflammation. So evaluation, pre-operative evaluation is very essential. Along with history, proper history, we should carefully evaluate the best corrected visual acuity, slit lamp examination along with pupillary evaluation, and ophthalmoscopy. This is one case scenario where patient came with a retinal detachment, traumatic retinal detachment in the, one eye, and he was not aware of any condition in the other eye, but on clinical examination you can see there is signs of sympathetic ophthalmia in the other eye. So other eye examination is equally important. These are the basic tests that we can do, already discussed: ultrasonography in case of media opacity, X-ray or CT scan to look at intraocular foreign body, VP to detect any optic nerve pathology, and ERG, that is more important in case of a retained metallic foreign body to detect signs of siderosis. So one more important thing is proper patient counseling. So goal of management is identification of all retinal breaks, release of all retinal traction, removal of intraocular foreign body if present, and retinal reattachment and long-term retinal stabilization. So, scleral buckle versus vitrectomy, selection of procedure correlates with the general principles of RD management, like a fresh RD without PVR, look at breaks, you can go for scleral buckle. But in other cases, many cases, vitrectomy is preferable. Indications of vitrectomy are PVR sense, vitreous hemorrhage, evidence of vitreous or retinal incarceration, large multiple posterior tear, and persistent intraocular foreign body. So probably the most debatable question is time for vitrectomy, whether it is early vitrectomy or delayed. So early surgery has some advantages, like immediate RD surgery may be performed during primary repair. A timely enucleation can be performed to reduce the risk of sympathetic ophthalmia if exploratory vitrectomy discloses severe damage and there is less incidence of PVR. But it is often difficult and unpredictable due to inflammation, bleeding, wound leak, and media opacity, maybe often associated with corneal edema and corneal opacity. Delayed vitrectomy has some advantages. Delayed vitrectomy performed after 7 to 14 days. By this time there is reduced inflammation, there is reduces risk of intraoperative hemorrhage. Spontaneous PVD induction may occur in many cases, gives time for additional evaluation and detailed prognostic discussion with the patient, and in case of posterior perforating wound, there is often a spontaneous healing of wound may occur. Late detachment may occur secondary to penetrating trauma and are often characterized by traction elevation of the vitreous base and the retina opposite a scleral wound. Progressive contracture of transvitreal membranes may cause late dialysis. So these type of cases are often associated with thick membrane which needs manipulation with sharp dissection and combination of instruments like scissors, knives and forceps. Traction detachment of the peripheral retina may additionally be supported by broad encircling buccal with limited height. Repair of retinal detachment complicated by incarceration and scar contracture may require relaxation by retinectomy or retinotomy with membrane dissection and PFCL use. And in some cases where there is corneal opacity associated with retinal detachment, vitrectomy can be done with temporary keratoprosthesis followed by penetrating keratoplasty. So in conclusion, before going to manage a case of retinal detachment secondary to trauma, we should have a proper management plan. We should choose treatment option that is best for the eye, not convenient for the surgeon. And we should not start an operation if the surgeon is not sure of optimally completing it. And if we have any doubt, we should refer the patient to a colleague experienced enough to handle the situation. Thank you.